Good evening, everybody. Thank you all very much for coming along to the Back Pain and Functional Movement Training Centre, which are integral parts of my surgical practice, City Coast Neurosurgery. We have a packed program tonight, and I trust that you will all learn some valuable information, in particular in relation to how we as a profession can understand and manage low back pain more effectively. Spine-related pain is one of our nation's most significant clinical and economic health burdens and desperately requires the likes of multidisciplinary centres of excellence to manage this very non-benign condition more effectively. So let's get on with the big question. Why do we have back pain? First and foremost, we as medical or allied health professionals need to accept the gravity of the problem and recognise that we aren't doing a great job at eliminating root cause for this condition. If we look at all patients in Australia with chronic low back pain, 745 have had surgery for their back pain symptoms. That is a drop in the ocean compared to the other 1.5 million people who are in the community seeking help from the spine health industry, which includes all of us and physical therapists. That number of over 1.5 million is increasing as time goes on, and it's not because of an aging population. We can't simply continue with the usual conventional deep tissue release, massage, core strengthening and stretching programs and exercise programs and think that suddenly they'll all start to make a difference. There is no evidence of effectiveness for this therapy, yet this has remained the default treatment advice for acute and chronic low back pain for 50 years. Earlier this year, I introduced the concept and a new term, failed back pain rehabilitation syndrome. It's been met with some opposition from physical therapists. Unfortunately, its existence is undeniable. Why is there opposition to this term? Because it means we all have to take accountability for patient outcomes from our rehab, from our intervention. No different to how a surgeon has to take accountability for surgical outcomes and failed back pain surgery syndrome, which is clearly accepted in peer-reviewed literature. Failed back pain rehabilitation syndrome is now being recognised by our peers and is being discussed at Harvard Medical Rehabilitation Centre. Back pain is a condition that is being so poorly managed that the WHO considers it to be the leading cause of disability worldwide. Ubiquitous and clearly apparent that we are failing miserably to manage it. It's one of the most common reasons people visit their GPs and the most common reason for multiple days off work. It represents the top economic health burden for industrialised nations, with expenditure in the order of hundreds of billions. A large proportion of the back pain therapy industry is simply massaging the natural healing process of the body and claiming that as treatment. A lot of conventional therapy, therefore, is coincidental, not cause for symptom improvement. And hence, it is no surprise that relapse rates for acute low back pain approach 75%. So once we acknowledge we have a problem, we then need to have a clear understanding of a disease that causes symptoms. Locally and globally, we are far from this point. If I ask the audience, what is the disease that causes wheezing and shortness of breath? We will all likely say something like asthma. If I ask the same for what is the disease that causes the most common form of low back pain, referred to as non-specific low back pain, we get answers like it's complex, biopsychosocial causes, multidimensional, nebulous explanations. There is no concordance. It's a cop-out. This is evident by the very name assigned to the condition, non-specific. Successful outcomes are doomed from the beginning with this mentality of labeling the disease as the very symptom it causes. Imagine saying to your patient with asthma, "Oh, you have non-specific shortness of breath. Let me treat that with oxygen." That's sort of what our peer-reviewed literature is guiding us to do with low back pain. Causation can be broken down to three simple principles. Structural deficits are obvious. If we have a fracture, infection, tumour, or an inflamed joint or nerve root compression, it will be an unpleasant sensation, painful. Functional deficit is poorly understood, and I want you to have a good understanding of that by the end of the evening. And the balance between functional capacity and functional demand is probably given even less consideration when someone with back pain is sitting in front of you. All the while, this is in fact the ultimate metric that we need to be targeting to restore spine health. So let's talk a bit about that. The key to understanding this important concept is to recognize that structure, function, and capacity are all interrelated, and our ultimate goal is to have a functional capacity higher than our functional demand. That means we can do more stuff and definitely do more than what our lives demand of us. If you uphold that principle, you will have a healthy, robust, pain-free musculoskeletal system, which of course includes your spine. Let's focus first on structure and function of systems. Every system's efficiency or capacity, whether it is biological or mechanical, is dependent on this important principle and interrelationship. Will a software reboot fix this phone? No. It needs a structural repair, a new screen. In the case of severe depression, am I likely to see a structural abnormality on this MRI? No, because it is a functional problem. There are many examples of this, like the structural flat tire making it difficult to drive functionally well, and conversely, a bad driver causing structural breakdown of the vehicle, or in biology, a structural lesion of the heart, like a valvular stenosis causing an arrhythmia, or conversely, an arrhythmia causing a structural infarct of heart muscle. Structure and function are strongly interrelated. Nowhere is this principle more relevant than in spine health. Now, I don't have a perfect MRI spine like this, and I don't move with perfect function like this Olympic weightlifter. Yet, I don't suffer back pain as long as the interrelationship between my structure and function provides me with a functional capacity that meets my functional demands, and I'm in total control of what my functional demands are. Now, I see lots of people with perfectly normal spinal structure on their MRI who are still disabled by low back pain because of their terrible functional movement. These are the patients who are in disbelief when you tell them that their pain is not coming from any structural problem in the spine. Much less commonly, there are some people who function and move very well, but have structural issues, for example, a pars defect or infection or tumour that opens them up to pain if they exceed their compromised functional capacity. The most common scenario, however, is that patients acquire progressively poor function, which drives progressively poorer structure, and they walk a tightrope of trying to remain within their steadily decreasing functional capacity or risk the onset of pain. And this is why we hear patients describe a steadily increasing and restricted lifestyle to circumvent pain. We all have to meet functional demands in life, be it a mountain climber or office worker or grandma in a nursing home. How can we optimize functional capacity in this equation? It's simple, really. We optimize the structure of the spine with structural remedies and optimize the function of the spine with functional movement therapy, which is the functional remedy. Only a tiny proportion of patients with low back pain require surgery, but almost 100% of patients with back pain require functional movement therapy. What is functional movement therapy and why do we call it NeuroHAB? Because it is distinctive in its target. being central nervous system motor patterns that dictate your movement proficiency. Think about it being like brain training to move skillfully in daily life activities, or what I refer to as the sport of life, which we are all active participants in. Thus, functional movement therapy and NeuroHAB is very different to conventional rehab approaches like these, which is a little bit like going to the mechanic with your broken car repeatedly because you skipped going to the driving instructor. When you think about it, these are really structural methodologies with zero functional upskilling of movement proficiency or function. So functional movement therapy and the NeuroHAB program is like the driving instructor for the human vehicle that spares you from having to go to the mechanic. Will gym and Pilates make you stronger? Yes, probably, if you work very diligently, but that isn't what patients are wanting. They don't knock on the physical therapist's door asking for a stronger core. They go there asking for help with their back pain, and what they leave with is a core strengthening program and persisting back pain. They are simply a stronger person moving poorly because strength does not mandate skillful movement. Is low back pain complex, like much of the industry believes? No. What makes it complex is our clinical experience and not understanding the discriminator. So let me explain. I'll have a patient that walks in and they'll explain to me, or they'll tell me why they have back pain. It's because they're sedentary, or because they're a office worker, or they'll say that it's because they're overweight, or that they're really unfit and have a weak core, or they're always tight. They've been tight their whole life, or simply because they're too old. But what I need to explain to them is that, hang on, the last patient I saw was super active. The last patient I saw was underweight. The last patient I saw was an athlete or a yogi, and a 20-year-old who's already had surgery and still in pain. And this highlights that we must understand what is actively causing pain symptoms in all of these individuals and not lazily attribute pain symptoms to the wrong discriminator because it suits that scenario. That's very unscientific. The discriminator or disease causing low back pain symptoms is movement dysfunction. Patients will have this relapsing remitting course until movement dysfunction is eliminated. So this is what I want you to be thinking at your next back pain consult. You'll probably have several tomorrow. Doc, I keep having flare-ups of back pain. The doctor says, I wonder what her spine structure is like. More importantly, what is her spine function? I bet she moves poorly in activities of daily living, which sets her up for a poor functional capacity. I know exactly where I need to send her, to the Functional Movement Training Centre. Of course, if you're worried about clinical signs or symptoms, then get imaging. It's essential. Now, if we don't adopt this approach, all we can do for our patients is manage symptoms and wait for them to maladapt. Sadly, maladapting is almost a treatment paradigm or prescription delivered by much of the industry, leading to progressively more maladaptations as time progresses. Like this: if it hurts to bend, don't bend. If it hurts to lift, don't lift. There is absolutely nothing wrong with this fellow's spinal structure, yet he remains incapacitated after a minor strain injury to his back. He engaged in couch-based passive and manual therapy for 6 months, with zero attention to reacquiring functional movement skill, and you can observe how disabled he remains. If it's not a structural condition driving his symptoms, it has to be a functional problem. None of these guidelines from the recent 2018 Lancet Back Pain Review recommend addressing movement dysfunction at all. The industry is almost solely focused, if not obsessed, with symptom management and structure-focused therapies. In the same international Lancet guideline discussing causation of low back pain, they say we don't know what causes low back pain, or they are completely structure focused as causation. Yet in the same sentence they go on to say, ignore those structural changes because they are not relevant anyway. Everyone's got bulging discs and they don't necessarily suffer back pain. The world's leading researchers are demonstrating a lack of understanding of the discriminator. Not one sentence considers a functional movement problem to be driving the epidemic. And that explains failing complex back pain treatment algorithms like this, as opposed to this, complex, simple. Occam's razor principle tells us that this will succeed and this will fail. And remember that epidemics, by definition, usually have a very simple root cause, otherwise they never reach epidemic status. It is difficult to imagine how an epidemic of back pain could be created when the currently proposed melting pot of biopsychosocial and multidimensional cognitive behavioral factors all have to come together like a perfect storm in order for you to become a back pain sufferer. All right, well, let's move away from the more common functional pathology and talk about structural pathology. It's certainly much less brain taxing than solving the world's leading cause of disability. These are the most common structural pathologies that develop from poorly managed chronic pain symptoms. If you let the functionally driven pain continue, patient's structure will break down and they will eventually become candidates for structural surgery. Now, I've got sacroiliac joint at number 1 because I think it's the least well understood and probably a lot more common than you think. And we'll get as far into these other more familiar conditions as we can until my time runs out, which I am notorious for.